We have a lot to go through today, and also we're so excited to see so many people here. It's really wonderful. I'm Natasha Bonham, Chief Strategy Officer at Genetic Alliance, and we are going to start off with introductions. I know there are a lot of people in the room, but we thought it's always helpful to know who's here and who's also having the same challenges around communication that we're having. So I'll have Andrea do a quick introduction of herself, and then we'll go quickly around the room.
I'm Andrea Goodman, Director of Engagement at Genetic Alliance.
Hello, everyone. This is Matthew Lane. I'm for
We'll probably have to really project our voices if you don't mind.
I'm Carrie Jepka. I'm the Research Manager for Parents as Teachers at the National Center.
Good morning. I'm Donna Elchel, and I'm with West Hawaii Community Health Center.
Good morning. I'm Trudy Esch, an MCH nurse consultant with the Michigan Department of Health and Human Services.
Hi. Good morning. I'm Helen Hannigan. I'm from the Southern New Jersey Perinatal Cooperative in Southern New Jersey.
Hi, I'm Emily Farrell. I'm the epidemiologist for early childhood development in Kentucky.
Hi, everyone. I'm Joy L. Meyer, and I'm from North Dakota. I'm the Newborn Screening Program Director.
Good morning. I am Nikki Palacios. I'm the Health Promotion Coordinator at the Utah Department of Health.
Good morning. My name is Jackie Kennedy. I'm the Program Manager for the Nevada Statewide Maternal and Child Health Coalition.
Hi, my name is Sarah McCassin. I am a project manager for New Steps 360 at the Colorado School of Public Health.
Hi, I'm Lucy Gibson. I'm the Director of Children's Health and Perinatal Services at South Carolina Department of Health.
Hi, I'm Sarah Toome. I'm with the Pennsylvania Department of Health, Bureau of Family Health, Program Manager overseeing Title V and SSDI.
And Erin McCarty, also from the Pennsylvania Department of Health, Bureau of Family Health.
Hi, I'm Jessica DeMontsabert. I am a Senior Research and Evaluation Associate from AEM Corporation.
Hi, I'm Alex Long. I'm a KDB Fellow in the field of social work from Indianapolis.
Hi, I'm Emily Healy, and I'm the PRAMS epidemiologist with the Montana Department of Public Health.
Good morning. I'm Lee Warner, the Chief of the Women's Health Fertility Branch at CDC, Division of Reproductive Health.
Good morning. I'm Cleo Basilius with the Title V program from the Republic of Palau.
Good morning. I'm Brittany Stokes. I'm Community Health Worker Supervisor with Urban Health Plan's Mitch program.
Good morning. My name is Colette Sturgis. I'm the Program Director for the Maternal Infant Community Health Collaborative at Urban Health Plan in the Bronx.
And I'm Lori Morrell from Child Health Specialty Clinics, a branch out of University of Iowa. I'm a nurse practitioner.
Good morning. I'm Rabiha Ghaffar. I'm the Perinatal and Adolescent Health Program Manager at the Washington State Department of Health.
Good morning. I'm Melanie Susswine. I am a vice president with Summa Social Marketing. We're a private contractor that does this stuff, so I'm really interested in seeing it.
Good morning. Art Logston. I'm an assistant commissioner, Indiana State Department of Health.
Hi, I'm Stephanie Wolf. I'm an MCH perinatal consultant with the Kansas Department of Health and Environment.
Hi, I'm Lori Benton from Clay County, Missouri. I am the coordinator for our MCH program.
Hi, I'm Julia Abercrombie at the CDC with the Learn the Signs Act Early program.
Greetings, everybody. I'm Lo Berry with Reach Up, Inc., a not-for-profit community-based organization in Tampa, Florida. I'm president CEO.
Good morning. I'm Megan McDonald. I'm an MCH epidemiologist with the Florida Department of Health.
Good morning, everybody. My name is Agogo Igadan. I'm a graduate student at George Washington University, pursuing an MPH in maternal and child health.
Good morning. My name is Katie Spray, and I am the program supervisor for our Family Home Visiting Division at Hennepin County Medical Center in Minneapolis, Minnesota. And I'm also an MPH candidate at the University of Minnesota.
Good morning. I'm Lakeisha Johnson. I'm a program officer with the North Carolina Partnership for Children.
Blair Lund, Title V, Montana.
I'm Brenda Breslow, and I'm the program director of our Healthy Start Coalition in Tampa, Florida.
Barbara Maselli. I'm the program manager for Healthy Families Hillsborough and Tampa, Florida.
Good morning. My name is Leah Woodall, and I'm the MCH Director, Title V for Delaware Division of Public Health.
Hi, good morning. I'm Mickey Cooper-Williams, PD Region Maternal Child Health Program Manager with South Carolina Department of Health and Environmental Control.
Good morning. I'm Diane Buckner. I am the I'm the same as her, the Maternal and Child Health Program Manager with the Department of Health and Environmental Control, South Carolina.
Good morning, everybody. I'm Megan Hiltner with JSI Research and Training Institute, and we are the supporter of the amazing Healthy Start grantees, maternal child health funded Healthy Start grantees, and the Title X Family Planning Resource Center there. So, yeah.
I'm Gabrielle Gasaway. I'm a public health educator and consultant for the newborn screening program in the Tennessee Department of Health.
Hi, I'm Rebecca Reno. I'm a postdoctoral fellow at the Best Baby Zone, which is at the University of California, Berkeley.
Hi, I'm Lauren Schwarzler. I'm a Master of Public Health student at University of Illinois at Chicago.
Sherry Santa, Medical Education Program Coordinator and F2F Coordinator in Texas.
Hi, I'm Kristen Silcox, and I am the MCHP at the Maryland Department of Health.
Hi, good morning. I'm Kristen Newman, and I'm with the Prince George's County Health Department, and I'm a program supervisor for maternal and infant programs that improve outcomes.
Good morning. I'm Brenda Thorne, and I'm a nurse with the Prince George's County Health Department.
Peggy Sayer, Title V with the South Dakota Department of Health.
Good morning. Florine McClain, City of Detroit Health Department, Community Health Worker.
Tammy McCory, Director of Maternal and Infant Health at the Detroit Health Department.
Good morning. I'm Athena Hall, Program Coordinator at the Detroit Health Department, and I'm also a PhD candidate at Walden.
Good morning. My name is Elise Parks. I'm an intern with the America's Health Ranking Reports and a graduate student at the University of Minnesota studying maternal child health epidemiology.
Good morning. I'm Teresa Volan at the Washington State Department of Health, and I work as an epidemiologist and the manager for surveillance and evaluation.
Good morning, everyone. I am with New Hampshire, McVie, and newborn screening.
Great. And I am Jackie Seisman, and I'm the Assistant Director of Maternal and Child Health Programs at Genetic Alliance. And we also have Annie here.
Hi, I'm Annie Evans. I'm the Program Coordinator for Babies First Test at Genetic Alliance.
Excellent, and we did all of that under 10 minutes, so that was perfect. I think this really shows that we have obviously people from very near and also pretty far away, a range of different disciplines and working in a range of different types of organizations, but all clearly very interested in messaging and behavior. So welcome, we're really excited to have you here. I am going to go through these first sets of slides that talk about expecting health and who we are fairly quickly so that we can get to the meat of the program, but I wanted to frame the work that we're going to be doing here today. And so we will jump into that. So Expecting Health is an initiative out of Genetic Alliance, which is a health advocacy organization that's been around for, I think we're in our 32nd year now. And through Expecting Health, we really are focused on how do we bring the science, policy work together and have that be informed by family, individual perspectives. For us, it really is about the fact that families deserve and should expect more. Our name, Expecting Health, is no matter what your situation is, no matter where you are in your health journey, you should expect health, and that's really defined from that family perspective. We know that education and support don't start or end at childbirth, that there's a whole set of support and needs that emerge. Our work right now really does focus in that period, but we know that it is part of just an ongoing continuum. I've talked a little bit about kind of our idea around everyone really should expect health, and that we really are looking to bridge that science-based information and actual real-life strategies to help parents and parents-to-be make the best informed decisions for themselves. This covers a little bit of our approach, looking at things from an engagement perspective, the communications, science, advocacy, user experience testing, as well as different types of assistance. So we work with a number of different groups around their educational efforts, but not just about creating the material, but what are the strategies around that, and how do you get informed from your constituents, from the families that you're working with, to see how your approach is going and how do you evaluate that, and then be able to build upon that. So why does messaging matter? When we are looking at how moms and families search for health information, we know that women are more likely than men to seek out health and illness information and answers related to specific symptoms after visiting a doctor. So it doesn't just start and end within that clinical visit. It really is beyond that. We also know that women are more likely to worry about getting more reliable information, and I forgot to mention, this is being recorded, and then you guys can always follow up and look at where we got our information from. The references are in teeny, teeny, tiny print that I can't even read up here. So you guys can definitely have that at the end of the session. We know that increasingly moms are turning to the internet and social groups for trusted information, and while women increase their health and nutrition knowledge after searches, they are not as likely as men to seek medical attention or advice as a result of their search. So there's a lot of science around the reasons around that, but we know that this is happening. We know people are going out looking for more information online, and that can be really great or really dangerous. And a lot of the work that us in the room are doing is how do we tap into those already established channels, particularly online, but not exclusively, to get the messages that we think are important out there. So steps in effective messaging. It's important to ask, who are those trusted sources of information? We've done a number of focus groups, and oftentimes we've had some of our colleagues ask, okay, ask these women, do they trust their doctor more or what they find on the internet? And it's like, no, that's not the right question. It's really, what are the messages you're getting? How do you incorporate them into the decisions that you're planning on moving forward with? We want to know, where do your members access the information? What are all those different channels? We know we're all bombarded by messages, but really thinking about where are people going, both what's online, but also those maybe in-person trusted sources, depending on the different communities that you're working with. And how do you gather a professional, family, and other perspectives? I think this isn't just, we know our work sometimes has a beginning and end date based off of a grant, but we know that isn't how real life works, and people are always getting more information and always looking to build upon their knowledge. So it's important to think about the accessibility of the message and tailoring the content and the format to your readers. We all have and from the perspectives that we come from, whether it's newborn screening or infant health or other places that we know, gosh, it'd be great if just every woman or every family knew this. And that's great. That's a wonderful starting point. But we also need to think about what is the information in the format that people are like, ooh, I really want to pick that up. Because if those don't match, then we'll have great information going out there, but not going to who we really want to pick it up. So that's another thing to be thinking about. You want to consider the social determinants, benefits, and barriers. What is your reader going through? We know there are those really key important messages that we want people to know, but if they're not there yet, if they're trying to deal, where's the next meal coming from, or how am I going to get my family established, then it's really difficult to start talking about something that seems really left field to them because it's not what their challenge or barrier is right in that day. And I think we need to think about that when we're going and trying to share information. And that really leads to segmenting the message based off of the specific audience and putting in place feedback loops and support iterations and improvements of message dissemination. Now, I would say none of that is rocket science. I didn't see anyone go, oh my God, what? I have to ask That didn't happen. But we know that we get really caught up in all the things of trying to get products out or meet our different deadlines, that sometimes it's helpful to go back and say, okay, let's reframe. Let's go through this. Are we really matching these different points? So it's important to make the information trustworthy. The image over here is a It's a website, but it's more like a web tool that Genetic Alliance created a number of years ago called Trust It or Trash It that can be used by either someone who is creating a material to get information out, or for someone who's looking at something to say, should I trust this or trash it? So of course it's looking at who, making sure you include who wrote it, who provided the facts, where did the facts come from, and who paid for it. The important thing here is not to say that any of these questions have right or wrong answers. It's just the things to be thinking about. We all know there are plenty of things, let's say for who paid for it. There are plenty of things that are paid for by a range of different people, and that's just one data mark to be like, oh, that is a trusted site that I'm not very familiar with them. Maybe I should look a little bit deeper. We want to see when it was written or last updated, and then how. How do you know this information pertains to you as that reader or that audience, and does the information seem reasonable based on what you've read and what you know? So nothing is alone and a standalone. It's really taking that within the context of other things that audiences are seeing. And you can find this at trustortrash.org if you want to see that image a little bit closer up. So now I will hand it over to my colleague.
Thanks, Natasha. So as Natasha was alluding to, I think we frequently look to, we as a field look to the evidence to support information that we want to disseminate to our members or our constituents, but we don't often pay as much attention to the communication science that empowers people to actually put that information into practice in their lives. And as we mentioned, there are so many variables that go into making sure that a message is appropriate for an audience and therefore they can translate it to their lives. And one of the key challenges that we all are dealing with even more than ever lately are the contradictory messages we're seeing in the media and even in our professional space that make it really challenging for all of us to take in what the key information is and really make it challenging for us as professionals and for people and families to understand how to actually access it and make it real for their lives. So we are going to share an example of something we've struggled with in terms of message dissemination as a result of contradictory messages, and we're also going to embark on an exercise today, probably within our tables because of the amount of people we have in the room. First, I just want to go through some examples of stuff we've seen in the field, and you'll note that none of these are going to be new to you, and we're all struggling with the challenges of the data that's emerging and the mass media that's picking up on it very quickly in this space. So a core example to our professional space, of course, is the advocacy space of breastfeeding. We see pretty consistent messages in maternal and child health around the guideline of exclusively breastfeeding for at least the first 6 months of life. Here's one piece we took from WHO. Of course, we also have similar guidelines from the AAP and others, and so we pretty consistently use this message as a field. Everyone's nodding. But we also know that the people we work with and even us are bombarded frequently by contradictory or confusing messages that make it more challenging to understand how do I actually do this. One is around allergies and the body of literature that's emerged over the last decade or so around how to reduce the risk of allergy, and of course, when to introduce solid foods. We've seen our guidelines change around that over the last decade or so as well. So lots of confusion added there to how to incorporate solid foods while still exclusively breastfeeding. And then, of course, in the mainstream media and the persistence of sometimes very useful mommy bloggers and other individuals who have come into kind of power in this space, we see lots of dialogue around the challenges for women around that guideline and whether it's realistic for people's lives, everybody's lives, just some people's lives. What does that do to somebody when they're going through that emotional experience in the first 6 months of life? So lots of confusion and challenges there for us as a public health community. Sleep training, for me, when I had infants, this was the #1 topic I needed to know about because sleep, of course, is critical. And as a professional and many women and families, you immediately turn to, obviously, Google to find out, is it safe to let my baby cry it out? And I'll just click through here because I don't even remember the nuance of each of these articles, but of course it's really all over the place. You can find data to support the fact that crying it out will of course harm your baby. It will be detrimental to their lives in adulthood. And you can also find evidence to support the fact that your baby will be absolutely fine and it's actually beneficial to allow them to cry so that they can get a good night's sleep, and so can you. And of course that's what I went with. But it is very challenging for families to decide what makes sense for us, and it may not always be the same answer for everyone, of course. Skin-to-skin contact, we've seen so much of this in our professional space, and I think much of the general public actually even knows this term now because we've seen changes in hospital guidelines and in healthcare provider practice. And so we see a lot around the benefits of what they call kangaroo care in the neonatal space or skin-to-skin contact. But we also see concerns about SIDS emerging in the media because of the baby sleeping on mom or dad. So could be a little scary for parents who are reading this in the media. Similarly, bed sharing has emerged as a place, I would say maybe of conflict for our field because of course there are benefits for lactation and supporting the breastfeeding relationship and the bonding relationship with the parent, but there are also dangers and risks of SIDS as we've seen in the literature. So very scary for people to think, well, I do not want to put my baby at risk, but I also want to do what's best. How do I actually approach the sleeping situation in my house? This isn't just a message that we're sharing at the national or state level. It's something that people have to think about. What do I do in my house? Safe sleep conditions, similar. We've seen change of practice and really a cultural change around putting babies on their back to sleep. It's been widely adopted. We've seen lower SIDS rates as a result. But then we've also seen a lot in the mainstream media and had a lot of research funded around what this does to flat head syndrome and risk for babies' development. So again, confusion there. I think just as a last example, the ever issue with a colleague use. I, as a maternal and child health professional and as a parent, still don't know exactly where we want to align on this because we do see documented risks and benefits. What do families do? Do I introduce a pacifier or not? And I don't think we've gotten to a place as a field where we've messaged this in a clear way for ourselves or for families. So with that, I think it would be helpful if we stayed at the tables we're in. We're going to break out into an exercise to think about a topic that you're currently struggling with to this point about conflicting messages. What is that message that you want to get out to your communities that you're tasked on working with? For some of you hearing your titles and spaces, it sounds like you work in pretty specific funded programs where you're being charged with messaging or disseminating information about one specific topic. So feel free to suggest something like that to your table, but you probably want to pick one thing as a table and go through the exercise, the worksheet. Maybe if I could speak to the actual worksheet. Sorry, I don't have one in front of me. Okay, so you'll see, those of you who have the worksheet in front of you at this point, that we're asking you to first outline what is the primary message that you're trying to convey, who is the target audience you are disseminating to in this case, who do they trust, to Natasha's previous slides about assessing who the trusted messenger is and how you could potentially utilize that trusted messenger to get out your key points. Considering some of these confusing messages that they're also going to be inundated with and will therefore be barriers to implementation. And then thinking about those channels. Where do they go to access information, and how can you capitalize on those channels as a way of influencing behavior change as a result of your message? So maybe we can go through some of those steps together. It's okay if it's out of order or not exact, and then come to some sort of conclusion as a table as to what your final, very brief, clear, and positive message may be. And we'll give you, how much time do we think? About 10 minutes to work on that before we reconvene. Does anyone have any questions on that? Okay.
All right, everyone. It's that time for you all to reveal your brilliant messages and processing through this. So we're going to get started. Great. So we have Annie and Jackie are going to be walking around. At first, are there any volunteers who want to share the messages that they started off with, what they ended up with, and I think more importantly in this, just the process of that. What was it like to actually go through those questions and think about them, think about the challenges and barriers. So who wants to volunteer? Oh, that got people quiet. I know. Or just share where you got. I think that's a very important point, that this stuff takes time.
I'm just going to start picking. Okay.
We had wanted to work on a message promoting home visitation, and that it's a positive thing for all families in our community. And we were talking about the conflicting messages would be, from families and friends. So often you don't want anyone in your home. The tie would possibly child protective services. Also the conflict that you can get everything you need from the internet. We had one woman who really shared a social marketing campaign in Delaware and how they're doing more with Instagram and some of those things. We did not come up with the perfect message, though.
That's okay. I think that's a really good, thank you for volunteering and going first. I think that's a really good example of even programs that we in this field know are just a slam dunk, that there still can be challenges to that. And, things that are really, not just cultural, but really embedded in our lives and in our family culture in terms of no, you don't have someone come in. It's a time to nest and to settle. So I think that's a really good example. Who's next? Who wants to share? Sharing is caring.
So we focused on safe sleep messaging, and a lot of the places are struggling with that message and the contradictory messages. We also did not have a time to come up with a perfect message to make that happen, but we talked about the struggle of bed sharing and the contradictory messages around, breastfeeding for that, and also we talked about the trustworthy messenger and the target audience really being the influencers to the mom, the nurse, the dad, and the grandmothers to try to get that message across about the no, not bed sharing. So we needed more time, but it was a very good conversation.
Excellent. Who's next? We have time for a couple more. Oh.
All right, so our three messages that we, focus on: social support, stress management, and breastfeeding. The target audience is low-income pregnant women in the city of Detroit. They trust peers, so we offer peer-to-peer counseling. Right? Okay. We could not get to the conflicting messages part, but the barriers, it's just like a misunderstanding of the program and what we offer, and just kind of wanting a friend and not really understanding the concept of social support. And then our target audience, they access information kind of via Google, Facebook, and so we use a lot of social media and then community meetings. And we didn't get to draft a message either.
Great. Well, so we actually are doing really well on time.
So we picked a very specific question around when a child should have their first dental visit, because there's some conflicting information on when they should go. We talked about the target audience being families with children, 0 to 1, physicians, and since I'm with parents as teachers, home visitors as a good target audience. We talked about some of our barriers are around access, fear associated with dental visits, sometimes on the part of the parent, and then oral health may not necessarily being a priority for a parent who has a child 1 or younger. Our target audience uses the internet, doctors, other media, as well as home visits and other kind of supporters to get their information. And we had a small group, so we were able to kind of craft something. So don't be too harsh on us, but we came up with, give your child the gift of a healthy smile. Your child should have their first visit when they get their first tooth or by the age of 1.
Anyone else? I thought I saw a hand up. Yeah, I know, you got a message.
We also did not get a message, but that was very good, very clear. We talked about perinatal mood disorder, postpartum depression. We talked a lot about how the terms are tricky, but we were looking at how to try and deploy a postpartum depression initiative, and we have different experience around the table. In New Jersey, we've had a very long-lasting program that was sponsored by a governor previously, and we say "Speak Up When You're Down," which is I couldn't remember it. I found that. And what we talked about in terms of our audience were not pregnant moms and families, and also the community, so the faith community and other leaders that are trusted in terms of identification and the pressures of being the perfect mom and what that might look like. We also talked about the trusted sources as other moms, grandparents, and trying to get into areas like lactation support groups and other groups that moms go to regularly for support. Home visiting and the McVie models were also mentioned, and also identified some of the barriers in terms of family bias and cultural issues, and identifying when you are having the baby blues. And we also didn't get to a message, but we talked a lot about some good stuff.
Great, thank you. Any other hands? I think we could probably do one more.
Ready? But I just feel like we have experts at the table. Could I read your sheet or somebody's sheet? So we talked about fetal alcohol spectrum disorders, and we talked about the primary messages would be that there's no safe amount of alcohol during pregnancy, the baby is always developing, and that there are lifelong effects of a baby exposed to alcohol during pregnancy. Our target audience, we didn't focus on one. We kind of highlighted 3 different segments that could be targeted, and we looked at women considering pregnancy, women that are already pregnant, and community health workers or healthcare professionals. Who do they trust? When we talked about the peer messaging would be key. So healthcare providers messaging with other healthcare providers, and women messaging with women, and that sort of thing. And the conflicts would be really there is a lot of different information out there, and it's difficult. You can't really study women and alcohol, though there is evidence now. But we talked about the conflicting information out there, especially when, different providers. Sherry shared that there's providers in the state sometimes that won't give a hard answer. They'll talk about turkey sandwiches, but they won't talk about drinking or have a hard line when it comes to drinking during pregnancy. And then we did not, let's see, where does your target audience go to for information? Their parents or word of mouth, they get blogs, internet, doctors, other healthcare professionals. So lots of opportunities. We didn't come up with a final message, but I did really like, Sherry brought up something that I thought it just resonated for me, was like babies don't take a day off during development. Like something around that. I thought that was pretty powerful. And did I miss anything, group? It was a good discussion.
Wonderful. Thank you so much for sharing those perspectives. And also, I think really seeing that being able to have the opportunity to really talk through those questions can bring up different discussion points in and of themselves. And when we're really thinking about, what are those challenges or barriers, and also all the different audiences that we want to reach, because we know it isn't just one, it's, where are all the messages coming from? And while they may be targeted, or they may be the language might be slightly different, how important it is that all those groups still are getting the same message and they can really build upon each other as opposed to even being a little bit different. So I think all those examples were really great. So for the last part of our talk, we are going to focus on a particular example, and Andrew will come up and kick us off.
And I also wanted to just call your attention back to your worksheets where we have these little asterisks around some other considerations when you're crafting your message around which partners and allies, and sometimes I would say not necessarily allies, but sometimes if the conflicting messages are coming from a specific partner space or community, it would be really important to bring them in to fully understand where that confusion comes from and align on that message before it is disseminated out to the field. So it's really important to think about who those players are and include them in the development of a message or a campaign. And then considering attendance to that, the feedback loop. So how will you, a message like around the first visit to the dentist, such a great example, and a great message for 10 minutes of work. And I think something like that would be perfect to put out to the community and then say, what are our opportunities for gathering feedback from families on how this may or may not work for you? What does this mean for you? And also from key partners. How does it work for a home visitor or provider to include this message as part of their daily work or not? And how can we iterate as a result? Okay, but moving on from the worksheet now. We wanted to give you an example from a project we've been working on. It's been very near and dear to our hearts for the last many years now, because there has been a lot of confusion in the world around the benefits of fish and seafood consumption during pregnancy and postpartum and lactation. And we don't need to go through all of these milestones, but just to give you a sense of this emerged for us after the FDA put out revised guidelines for them in 2004, which were then entitled What You Need to Know About Mercury in Fish and Shellfish, which you can probably tell from the title spurred an enormous amount of fear, confusion, and risk aversion from women everywhere around mercury being in the title. And the document itself goes on to list a variety. It says something like, eat fish, but here's a list of all the fish you should avoid. This is why you should avoid it, and there's lots of mercury in fish, and obviously I'm distilling that for the purposes of keeping this brief, but so that you understand our process. Many advocacy organizations and others in the maternal and child health space became active at that point because we were very interested in making sure that women and families received not only positive but accurate information about the benefits of risk in seafood consumption during pregnancy, and that the message actually followed the communication science, so that we were putting out effective and scientific information, but in a way that made sense for people, that they felt empowered to make positive decisions for themselves and their baby. So obviously, for many, policy, whether you get involved in policy in a program, is a nuanced decision for an organization. Many of our organizations became involved in this on the ground because of the trust implications. What came out of the federal government had a lot of implications for trust and for behavior from families and communities. And there were lots of barriers to a piece of guidance like this, such as lifestyle. Obviously, fish and seafood is very particular for